Dear colleagues, I'd like to introduce to you my PhD topic about treatment possibilities in oro-maxillo-facial rehabilitation. My name is János König and I'm from the Department of Prosthodontics, and my vision is an evidence-based maxillofacial prosthodontics. To establish this, to reach this, we have to establish a proper scientific output for our work group. To reach this, here are my specific goals, and my first project is about 3D scanners used on the face, hence the title, Optical Scanning Should Be the New Standard in Facial Prosthetics. Well, every year, 650,000 people develop head and neck cancer, and some of them has a facial tumor that cannot be restored surgically. However, prosthetic treatment is inaccessible for many people. Through trickle-down effect, eventually the currently cutting-edge technology could eventually reach the masses, and therefore making this kind of care more accessible. Currently, to obtain a model of the patient's face, we have to take an impression of it, but this has numerous disadvantages, so therefore we need a safer, quicker, and more reliable alternative, and face scanning technologies seems to be the solution. Our aim was to compare industrial scanners capable of capturing a human face by comparing their trueness to each other. And this was done by comparing direct clinical caliper measurements which were considered to be the true values which were measured on the patient's face. And these were compared to the scanned models, to the measurements on the scanned models. And our hypothesis was that the laser scanning technologies, because they are slow, they would be the most inaccurate, especially the orolabial region, which is more susceptible for movement. The clinical significance of this, that if we have a scan model that is somehow in any dimension is distorted, then eventually the prosthesis would also be inaccurate. And this quick calculation was showing that a wider gap than 0.3 millimeters would be visible during human interaction. So this was our clinically acceptability range. We conducted a systematic search in 5 databases, and at the end, we got 10 eligible articles included in our meta-analysis. Through comprehensive data collection, we've collected all the useful information for this analysis, and eventually we got 8 interlandmark distances compared in 3 regions, but due to time constraints, I'm only showing you 3. What we can see here is that the heterogeneity was quite low in every case, and what we are looking at, the mean differences, would show how accurate the representation of the scanning technologies are. And what we are seeing is no statistical difference is present. However, the confidence intervals are consistently narrower than the individual studies' confidence intervals. But the red lines are marking this so-called clinical acceptability threshold, which in every case, the confidence interval is wider than that. Another analysis was conducted comparing multiple interlandmark distances at once to compare the different technologies and the different facial regions. So these 3 are showing the nasal region along the vertical, the horizontal, and the Z axis. And this was done through a standardized mean differences analysis, because the magnitudes of these interlandmark distances were different, and the same phenomena are to be seen here. So the confidence intervals are getting narrower and narrower. However, this doesn't tell us anything about the actual trueness. And the third project that we did in this article is that we've collected all the mentioned difficulties that were arising in the scanning procedure, and most of them were mentioning motion artifacts and different artifacts during the stitching of different images. The strengths of this review are that no regional analysis was conducted before on the face, and the low heterogeneity was coming from the same methodology that was used throughout all the articles. The limitations are that not all regions were involved, especially, for example, the auricular region is missing, and the involved population mostly consisted of healthy individuals, with only one exception who measured children with a cleft lip. And the gold standard measurements are still having their own flaws, so that's why they cannot be considered to be absolutely true values for comparison. Our conclusion is that the dimensions of these scan models are not significantly different compared to the directly measured true values. However, this doesn't imply that they are accurate, because the accuracy is not in the clinically acceptable range just yet. And the clinical usability differs from device to device. Even though they are not seem to be in the acceptable range, they are still having disadvantages that still outweighs the traditional impressions outweighs, the traditional impressions disadvantages outweighs the disadvantages of the scanning. So therefore, they are preferable in a clinical practice. And for further research, these same analysis should be conducted on actual people with actual facial deficits. We should explore the learning curve of scanner usage, and some research should be done on the giveaway features of facial prostheses, meaning that what kind of features would make you tell that these prostheses are fake. Currently, the manuscript status is under internal review. The revised version is up for comments and suggestions. The second project is about the treatment of patients with maxillary defects. These defects are a necessary part of the cancer treatment, and the restoration of this defect is absolutely necessary to provide the patient a better quality of life. But the means of disclosure is different. We could either use a restorative surgical option or a removable denture, and the choice between these two is still controversial. So our aim is to compare these two methods by comparing quality of life scores of different domains. These domains consist of speech, eating and drinking, appearance, swallowing and mastication. And our null hypothesis is that there will be no difference in quality of life. Therefore, since the prosthetic treatment has lower costs, less complications, and easier oncological surveillance, maybe prosthetic options would be a more widely used treatment. We conducted a systematic search in 4 databases, and at the end we got 16 eligible articles. Currently we are at data extraction stage with this one. The third project has the same PICO, but this one focuses on further on the back of the throat in the pharyngeal region, on the soft palate, because these are even more neglected prosthetic reconstructional options. So we need a protocol for a team of prosthodontists that how to fabricate such appliances. But first we have to prove the non-inferiority of these prosthetic solutions. And we've conducted the systematic search in 4 databases, and in the end we got 4 results. But these are using very different outcomes. So maybe a quantitative analysis is not feasible. But we fabricated we made 2 cases for a patient. The first one is for a patient who has a soft palate, but it's not moving very much due to a brain trauma. So therefore, this is a palatal lift prosthesis. And we fabricated a dynamic palatal obturator or a pharyngeal obturator with a complete denture for a patient that has absolutely no soft palatal structures. Currently, we are at the data extraction stage with this project as well. I would like to thank you for your kind attention with a quote by a race car driver. If everything seems under control, you are not going fast enough. Thank you.
You told that instead of making taking an impression, you want to use intraoral scanner. What do you think? Beside that technique, do we have any other alternative possibility? For example, using X-ray and using 3D printing?
Sure, there are options for segmenting a three-dimensional model from a computer tomographed image. It can be either a cone beam CT or a proper CT, or even an MRI machine, but these are not the best for surfaces, only for volumes.
And what about the soft tissue? Because the third topic about the soft palate.
There would be a try for segmenting these kinds of surfaces in the back of the throat, because there are some computer tomography devices currently that may be capable of providing this kind of information in a three-dimensional model.
And what type of material can we use for that artificial eye or ear?
Well, some kind of silicone, or I maybe don't understand this question.
And have you already examined it, the different materials?
Not yet, unfortunately.
Yes?
I have a question about your first topic. Do you think that different facial scanners can cause heterogeneity in your topic? Do you think that there will be differences between the facial scanners?
Yeah, if the scanning protocol is thoroughly set and the operator is strictly adhering to it, then I don't think that there will be any difference in regard of the technology.
Thank you for your nice presentation. I have only one question according to your third project, if I am right. That so you only have these 4 eligible articles for the qualitative analysis, as far as I understood it, right?
Yep.
And after this slide, you showed us some very nice clinical pictures. So do you plan to compose these together in an article, or your plan is to write a systematic review, or what is the further plan with this topic?
Thank you for the question. The plan is that these cases are now finished, and I hope that the information in these articles will support that these cases were treated right, and the protocol for these treatments are supported enough scientifically to be published.